And we're live.
Great. So hi again, everyone. Welcome to our first educational session of the day. We're delighted to have Dr. Stefanie Blain-Moraes with us today. Dr. Blain-Moraes is an assistant professor at McGill, where she runs the Biosignal Interaction and Personhood Technology Lab. Her training is in biomedical engineering and rehabilitation sciences, and she did a postdoc in physical medicine and rehabilitation, as well as anesthesiology. She applies physiological signal processing techniques and assistive technology design principles to address the needs of non-communicative individuals and their care providers. Her areas of expertise consist of enhancing interaction with non-communicative individuals and assessing levels of consciousness and cognition in non-communicative individuals. And we're so excited to have her here today to provide us with an introduction to the neuroscience of consciousness. So over to you, Dr. Blain-Moraes.
Thank you very much.
We can hear the echo. Do you think you can, do you have headphones?
I hear the echo.
Interesting. Can you try saying something?
How is this? Is that better? No, it's not.
No, I still hear the echo. Do you have two Crowdcast windows open?
Just one. Oh, just one.
Just one? Do you have other video chat software?
I will close things and see if that makes a difference. How's this?
Oh, it sounds good now.
Is it better?
Yeah.
All right, and can you still see my screen?
Yep, everything's perfect right now.
Okay, wonderful. Thank you for the tech support.
No problem.
So thank you very much for inviting me to be part of the Maine 2020 conference. It's really quite an honor and honestly a little bit intimidating to be speaking about the neuroscience of consciousness when yesterday we had some of the greats in the field, Anil Seth, Sanal Stehan. It's just, it's quite a privilege to be able to speak here today. So my goal over the next 40 minutes is to give those of you who are interested in the field a little bit of background and a little bit of an overview of the field of the neuroscience of consciousness. As Elizabeth said, I am a professor at McGill University, the Canada Research Chair in Consciousness and Personhood Technologies. So we're going to start off with an introduction to the history of consciousness science. We're going to take a few minutes to talk about the nomenclature in consciousness, because as many of you who attended the conference yesterday will have realized, when we talk about consciousness, it's often not clear what we are talking about. I'm going to talk about strategies that are employed in consciousness science. And then I'm going to draw from two examples from my research, anesthesia and disorders of consciousness, to illustrate some ways that we use neuroscience to study consciousness. So just a quick overview of the history of consciousness science. It's a very young field. It coalesced in the mid-1990s, and so this is very, very young in comparison to fields like physics and biology. People have been asking questions about what it means to be human and what it means to be in the world since the beginning of time, but the science of consciousness really only started towards the ends of the 19th century. William James considered consciousness to be the pinnacle of science, and that in this day and age, philosophy and phenomenology were both considered to be grounds for science, because the idea was we don't have science unless we have a self for observing the world. Moving into the 20th century, there was a marginalization of towards the science of consciousness, because there were two models of the mind that really predominated in the early 20th century. The first was behaviorism from the field of psychology, and in this field, they considered environmental inputs and behavioral outputs. And what happened inside the black box of the mind was not considered the domain of science. So in behaviorism, subjective experience was just off the table scientifically. The other major model of the mind that predominated in the early 1900s was psychoanalysis. So consciousness wasn't necessarily off the table with psychoanalysis. It was just not so interesting because the dynamics of the unconscious that drove behavior were much more interesting than what was in the conscious mind. So in Sigmund Freud's words, consciousness was nearly the tip of the iceberg. In the 1980s, the tide started to turn, and it wasn't really a major journal of consciousness until the early 1990s, when psychology had a lot more theories of consciousness. So one of these first theories came from Bernard Baars. He had a number of cognitive theories of consciousness, including global workspace theory. And at the same time, a number of prominent scientists and intellectuals turned their attention to consciousness. So Francis Crick of DNA fame partnered with Christoph Koch in the 1990s and turned their attention towards consciousness science. One of the papers that they wrote in the 1990s said that it is remarkable that most of the work in both cognitive science and the neuroscience makes no reference to consciousness or awareness. At the same time, Gerald Eidelman, who won the Nobel Prize for his work in immunoglobulins, turned his attention towards consciousness and mentored a young scientist named Giulio Tononi. And along another line of investigation, Sir Roger Penrose, who this year won the Nobel Prize for Physics, also turned his attention toward consciousness. So there was a coalition of forces of these major intellectuals who were all discussing the science of consciousness. It was still, at this time, a fairly small fringe field. You couldn't call yourself a consciousness scientist if you were on tenure track, for example, but it was starting to become something that people took a lot more seriously. Then in the mid-1990s, there was the first major meeting on consciousness in Tucson, Arizona. This conference is still ongoing to this day. It meets in Arizona every other year. And several journals appeared that published studies of consciousness, including the Journal of Consciousness Science and the Journal of Consciousness and Cognition. So this was really the birth of consciousness science. We are looking at a field that really is only about 30 years old. So if those of you, for those of you who are interested in joining the field, this is an excellent time. That you're still kind of at the very beginning of the major scientific study of consciousness. I want to turn now to just a quick introduction to the nomenclature of consciousness. We have a lot of trouble for describing what we mean by consciousness. And those of you who attended, for example, the panel yesterday, realize that even the prominent scientists talk sometimes around the term, and we don't quite know what we are talking about when we say consciousness. So there's a number of different definitions that are used in the field. One of the earliest was Nagel's paper, "What is it like to be a bat?" You have conscious experience if there is something it is like to be that organism. Another definition that is used fairly commonly is what disappears when we fall into a dreamless sleep and what returns the next morning when we wake up. This is Giulio Tononi's definition. The quote is, what abandons us every night when we fall into a dreamless sleep. But this is still not a precise definition of consciousness. And we have, as consciousness scientists, we have created many different terms and domains within the field to try and elucidate what we are talking about when we try and study the science of consciousness. So I'm going to go through a couple of these definitions and these terms before I turn to the neuroscience of consciousness, so that we have a better sense of what we're talking about. So the first distinction that I'd like to make is the easy versus the hard problem of consciousness. And this is a distinction that David Chalmers, a philosopher of mind, made. So this is a way of evaluating argumentation. There's lots of different features of consciousness and conscious processes. And David Chalmers makes the distinction between the hard problem, which is the problem of experience. So the phenomenology, the interiority, the sense of perspective, coming back to my previous slide, something that it's like to be in this mental state, that is the hard problem of consciousness. This is what is seemingly intractable about the problem, because I am privy to only one subjective experience, my own. Everyone else's subjective experiences I am making inferences about by their behavior. Our scientific approach is objective. How do we use an objective approach to explain a subjective experience? So this is the hard problem, the explanatory gap. Even if we assumed that we knew everything that there was to know about the functioning of the brain, how does experience fall out of that knowledge? So that is considered the hard problem. The easy problems of consciousness are really easy in principle only. These are problems such as how the brain integrates information from the different sensory modalities, how we detect features, and as I said, easy only in principle. The second distinction that I would like to draw is the distinction between the words awake and aware. So sometimes it's called wakefulness versus awareness. This distinction really came to light with the case of Terry Schiavo in the 1980s. This is a very poignant story about someone in vegetative state, which is now called unresponsive wakefulness syndrome. So she had wakeful behavior. Her eyes were open. She would look around the room. She could yawn. She could tear. She could drool. But there was a lot of debate about whether or not she was aware of her environment. And so we draw the distinction between having wakeful behavior and having awareness of self and awareness of their environment. And the awareness is considered to be a dimension of experience that is critical for consciousness. The next definition that I'd like to walk you through is the distinction between levels of consciousness and contents of consciousness. These two are often deconstructed in this orthogonal framework, which is potentially a little bit artificial, but still nonetheless a very useful distinction. So if we look at if we remember the previous slide, often wakefulness is equated to levels of consciousness and awareness is equated to contents of consciousness. The contents of consciousness here is what it's like to be in your subjective experience. Some people call this the qualia, and this is what we're experiencing subjectively. So what I could be aware of the green light in my face right now. This is the contents of my consciousness. The level of consciousness is how wakeful I am. In the state that you and I are in right now, both of our levels of wakefulness and our conscience of wakefulness are high. And it is a little bit artificial. Can you really deconstruct the two? Is it possible to have a high content of consciousness if you don't have a high level of wakefulness? There are probably more dimensions, and there's a number of really interesting papers that have been published recently. I'm presenting one here by Tim Baines that argues that there are many different dimensions of consciousness, not just content and level, and that we can evaluate things like disorders of consciousness on 8 different dimensions of consciousness. One of the things to note here is that the level and the contents of consciousness are manipulated scientifically. Anesthesia is used to modulate the level of consciousness, and we can use psychedelics to modulate or manipulate the contents of consciousness. So now that we have those definitions presented, I wanted to turn to some of the strategies that are used in consciousness science. This is a quote from the editorial from the inaugural issue of the journal, The Neuroscience of Consciousness. The editorial was written by Anil Seth, B.O.J. He, and Jacob Howie. They say that the main strategy within consciousness science lies in connecting objective third-person data about the brain and behavior with subjective first-person data about the properties of conscious experience, including whether they are present at all. Within this broad multidisciplinary scope, there is an increasing focus on the brain as the primary biological substrate for awareness. So as many of you voted in the poll yesterday, neuroscience is a very useful field for studying consciousness, as the experience arises from our firings of our neurons in our brain. So in terms of how we study consciousness, there are many different domains that the consciousness science uses to pull apart at what it means for us to be able to generate our subjective experience. People look at interactions between conscious and unconscious processes, selfhood, embodiment, and interoceptive awareness, as Nielsef talked about yesterday, metacognition and higher order consciousness, emotional awareness, intention, volition, agency, and awareness of others, individual differences in consciousness, altered states of consciousness such as sleep, dreaming, and anesthesia, disorders of consciousness, consciousness in infants and non-human animals. So the neuroscience of consciousness turns its attention to all of these different areas of consciousness science and looks at the brain's response to the various domains that are defined within them. So as neuroscientists, we often manipulate the different levels and the contents of consciousness. This was a slide that was presented by Stanislas Dehaene yesterday, showing that we can manipulate the contents of consciousness by presenting different levels of visual stimuli that are become from subliminal to something that becomes that we become aware of. And in measuring the brain's response to subliminally processed stimuli in the visual cortex, where you only activate the early visual areas, versus things that are past the threshold of our detection, where we can consciously process them, where not only higher order and prefrontal areas are activated, but we also have a recurrent or feedback processing that is activated or ignited once we pass the threshold of something that becomes consciously processed. This is an example of how we manipulate the contents of consciousness and look at the brain's differential responses to the various contents of that are being presented to us. We can also manipulate the levels of consciousness. So we can do this pharmacologically by using general anesthesia. We can also look at disorders of consciousness, pathological forms of consciousness, such as minimally conscious state and vegetative state. So I'm going to turn to two examples from my research to give you a sense of what it looks like to look at brain responses, or the neuroscience of two different forms of manipulation of consciousness. The first is anesthetic-induced unconsciousness. So the first slide I would like to show you, it actually comes not from my lab, but from the lab of Emery Brown and Patrick Purdon. They used propofol anesthesia and induced anesthetic-induced unconsciousness in these individuals, and recorded high-density EEG as individuals lost consciousness. This is the line, loss of consciousness here, and recovered consciousness. And they performed a simple time frequency analysis to create a spectrogram to look at the changing properties of the frequency content, the power of the different frequency content across time, and showed that upon loss of consciousness, we had an increase in alpha power. Upon recovery of consciousness, we had a decrease in alpha power. And by looking at the spatial distribution of where this traveling peak showed up, we could see that this was an anteriorization, an anterior dominance of alpha. They also looked at phase amplitude coupling of low frequency phase. So this is the phase of the EEG from 0.1 to 1 hertz, with the amplitude of alpha. So alpha goes from 8 to 14 hertz in the EEG. And we're able to show that when individuals were conscious, we had a trough max coupling. That is that the high power alpha, high amplitude alpha, was found mostly in the troughs of the low frequency waves. And when individuals switched over to a propofol-induced unconsciousness, the coupling, the phase amplitude coupling, switched over to a peak max coupling pattern. So our high amplitude alpha was found in the peak of the low frequency waves. And these have become quite robust markers of anesthetic-induced unconsciousness. In my lab, we built upon these findings. We didn't just look at the dynamics of the waveforms. We also looked at what anesthetics did to the brain network as a whole. So we conducted, this is data from my postdoctoral fellowship at the University of Michigan under the supervision of George Mashur. We looked at the anesthetic sevoflurane, which is an inhaled anesthetic. We collected data from 7 healthy volunteers while they were undergoing 64-channel EEG as they were gradually induced into a state of unconsciousness over the course of an hour by slowly titrating up the concentration of sevoflurane that they were inhaling. We looked at functional connectivity across different brain regions, and we used a measure called phase lag index. We were able to show that the functional connectivity, which measures the statistical correlation between 2 different signals, was significantly lower upon the unconscious state in frontal parietal, frontal temporal, and frontal occipital regions, and that this distinction, this change in functional connectivity strength, was visible on an individual subject level, not just on the group level. We also looked at directed functional connectivity, looking at frontal parietal feedback dominant connectivity during unconsciousness. And we were able to show that the frontal parietal feedback dominance that we see in baseline states when the individuals are conscious are neutralized upon unconsciousness. My colleague Anshul Lee at the University of Michigan took this a step further and looked at symbolic transfer entropy, which uses information theory to measure the causal interaction between a source signal and a target signal, and was able to show that across 3 different families of anesthetic, ketamine, propofol, and sevoflurane, in the baseline state, which is pre this blue bar in all 3 graphs, in the anesthetic state, humans have feedback dominance, so feedback in the red, feed forward in the blue, feedback dominant connectivity when we are awake and conscious. And upon induction, this which is at this blue line over here for ketamine, propofol, and sevoflurane, this feedback dominance neutralizes, and when we are unconscious, there's either a neutralization or sometimes even a reversal of the feedback dominant connectivity to a feed forward dominant connectivity pattern. So this is an example of how we use anesthetics to control and modulate an individual's level of consciousness and are able to look at the correlates of what is happening inside the human brain while we are switching from a state where we are aware to a state where we have no subjective experience. We can also use graph theory to analyze brain networks, which we've done in our sevoflurane study. So in graph theory, we use the patterns of nodes and edges and looking at the properties of how these graphs are connected together to be able to come up with some inference of how these networks are performing. We look at properties of network hubs, which are highly connected areas of the network. And with the same data set that I showed you before, we can see that the high degree nodes, the hubs, are posterior in the baseline phases. They shift to an anterior dominance when individuals undergo unconscious, sevoflurane-induced unconsciousness, and then they shift back to posterior dominance when individuals return and regain their consciousness. I'd like to switch to a second example that illustrates how we use neuroscience to get insight into human consciousness. And I'm switching to my work in disorders of consciousness, which I've been conducting here at McGill University. So I wanted you to recall this graph of wakefulness and awareness. And I want to focus your attention on the 2 states that fall off of this diagonal line: minimally conscious state and vegetative state, which is now known as unresponsive wakefulness syndrome. In these 2 states, the individuals have a high level of wakefulness. So their eyes can open and they exhibit wakeful behavior. But in minimally conscious state, individuals are intermittently aware of their environment. They can often command follow, but not consistently. Whereas individuals in vegetative state are, by definition, unconscious, unaware of their environment. The trouble with these two states is that when we clinically assess them in a regular intensive care unit setting, we often use something called the Glasgow-Coma scale, which is a 5-minute behavioral assessment. And when we use a more thorough tool, something like the Coma Recovery Scale revised, we realize that there's a misdiagnosis rate of over 40% of individuals in who are diagnosed to be in vegetative state who actually have some levels of awareness. So we're not good at drawing the distinction between minimally conscious state and vegetative state. Our inability to distinguish these two states was further shown in a seminal paper in the field by Adrian Owen in 2006, which showed that an individual who was in vegetative state was able to reproducibly follow commands in the fMRI. She was asked to either play tennis upon command, to activate her motor cortex, or to imagine navigating her house, and was able to show that reliably she was able to follow commands, even though she was diagnosed both with the Glasgow-Coma scale and with the Coma Recovery Scale revised as having been in a vegetative state. Damien Cruz in 2012 showed that we can also make this distinction with EEG. You can ask someone to imagine moving their right hand or moving their left hand, and some individuals in vegetative state can activate the appropriate part of their motor cortex in spite of a behavioral diagnosis of unresponsive wakefulness syndrome. So how do we draw the distinction between these two disorders of consciousness? I'm going to present to you some work from my fabulous postdoc, Dr. Catherine Duclos. She really drove the bulk of this study. So we recorded data from 12 patients with a disorder of consciousness. We recorded high-density EEG across this paradigm, where we had 5 minutes of EEG recorded pre-anesthesia. So this is their baseline state. We induced anesthetic. Well, we exposed them to an anesthesia, propofol, for 5 minutes, targeting an effect site concentration of 2 micrograms per milliliter. We held them there for 5 minutes, recorded 5 minutes of EEG, turned off the propofol, and when the propofol dropped below 0.05 micrograms per milliliter, we again recorded 5 minutes of EEG. We looked at 2 different measures of brain network function across these 3 states. We looked at where the network hubs were in the alpha bandwidth. So just as a reminder, where the areas of the brain that were most highly connected to other areas of the brain were. And we looked at the directed phase-like index, a measure of directed functional connectivity across these 3 states. We contrasted these alpha network hubs and the DPLI functions between these 3 states, and had, from this contrast, calculated something that we call the adaptive reconfiguration index, which is a measure of how well the brain is able to adapt itself to the perturbation of anesthesia. This is a little bit of a busy slide, but I'm going to highlight 3 particular individuals so that you can really see the patterns that are emerging. We grouped our 12 individuals into individuals that eventually recovered consciousness in 90 days. So this is the column on the left, and individuals who did not recover consciousness within 90 days. These are the 8 subjects on the right. And we compared, on this slide, we compared their patterns of direction of information flow in their brain network. I'm going to highlight 3 of them for you. So this first participant, participant 1, when we did the baseline EEG, this person was in a coma. You can see that in the baseline state, we have this red pattern at the top triangle, which is indicative of feedback dominant connectivity. And as you'll remember from the anesthesia slides, this is what we see in healthy individuals. When we give the individual propofol, this pattern reverses, and then we have blue triangles at the top, and this is indicative of feed-forward connectivity. And when we turn off the anesthesia, this patient's brain returns to a pattern of feedback dominant connectivity. This is what we see in healthy individuals. And this is in spite of this individual being in a coma when we recorded the data. 90 days from the date of recording, this individual was able to recover consciousness. I'm going to highlight two more for you. This participant was in unresponsive wakefulness syndrome when we recorded the data. He also has red triangles at the top right corner, which is indicative of a pattern of feedback dominant connectivity. But when he's exposed to propofol anesthesia, we still see red triangles at the top, which means that the brain was not able to reconfigure itself in response to the anesthetic. This person did not recover consciousness. And then a final participant to highlight, this is an individual who is in minimally conscious state. And you'll see that the direct patterns of directed connectivity are really scattered. There's no major group of a brain region, of electrodes over a brain region which show consistent feedback or feed-forward connectivity. And there's no organization of the reorganization of feed-forward connectivity when this individual is exposed to anesthesia. And this individual also did not recover consciousness within 90 days. We also looked at the individual's network's hubs as they received anesthesia. It's the same pattern as my previous slide. So my left column is individuals who recovered consciousness in 90 days. My right column is individuals who did not recover consciousness. I'm going to highlight the same three participants for you. Our first participant, who was in a coma, had posterior network hubs at the baseline state. When they received anesthesia, these switched to an anterior dominance, and then returned to a posterior dominance when we turned off the anesthesia. In this participant's case, we have posterior hubs which do not shift upon exposure to anesthesia. So the hubs stay at the back right corner across all three states, and this individual did not recover. And then we have our individual in minimally conscious state who has anterior pathological hubs throughout all three stages. So to create the adaptive reconfiguration index, we combined the measures of hub reconfiguration and a phase lag index reconfiguration into a two-dimensional plot. And we were able to show that we were able to achieve an accuracy of 100% in separating those who were able to recover consciousness in 90 days over here, from those who were not able to recover consciousness, simply based on how well their brains were able to reorganize, to adaptively reconfigure in response to the perturbation of anesthesia. So I highlight these two types of studies just to give you a little bit of a deep dive into what it looks like to use neuroscience to study different states of consciousness. The two deep examples I gave you were examples of shifts in levels of consciousness. And I wanted to just close this introduction by pointing you to some broader resources to look at if you are interested in the neuroscience of consciousness. So the journal Neuroscience of Consciousness was started in 2015. It's an excellent resource for current science that's being conducted in the field. We also have journals such as the Journal of Consciousness and Cognition. The Association for the Scientific Study of Consciousness is a fantastic group where many individuals who study consciousness science are affiliated. They have a yearly conference, which is outstanding. There's also the Center for Consciousness Studies in Arizona, which hosts another annual meeting. This meeting every other year is held in Tucson, Arizona. And then I also want to highlight the Center of Consciousness Science, where I did my postdoctoral fellowship. This is housed at the University of Michigan, led by George Mashur and Anshul Lee. These are all wonderful places to go and to look to see the latest findings in consciousness science, and to learn more about what's happening in the neuroscience of consciousness. And then finally, I'd encourage anyone who's interested, especially those of you who are listening who are Canadian, to contact me. I've been interested in forming potentially a Canadian group of researchers, anyone who's interested in the science of consciousness, to be able to form a Canadian network to address the problems of consciousness in our field, with individuals who are north of the border. That concludes my presentation, and I think that we still have 5 minutes left for questions, which I'm very happy to answer.
Elizabeth, you're muted. You're still muted. I'm trying to unmute you, but it doesn't allow me to.
While you're working on that, Elizabeth, I'm just going to go and look at the most upvoted question over here.
Yeah, why not?
Okay, so this is the top question here is, how can we distinguish between different states of consciousness? Do we have a method other than looking at neural activity, something like a behavioral assay? This is a very interesting comment. So there's a number of different cases where we've shown that the behavior cannot be equated to consciousness or conscious states. So, I mean, the best example of this is in disorders of consciousness, in something known as cognitive motor dissociation, where we have individuals who are able to command follow in something like the fMRI scanner, but have zero behavior. Another example is the case of intraoperative awareness, where you have individuals who are under anesthesia, paralyzed, and then in the middle of a surgery, suddenly become aware of their environment. And so you cannot couple behavior response to command with someone's ability to have a subjective experience. Elizabeth, I think that you're back, so I'm going to turn it over to you.
Yes, perfect. Sorry. No, thank you so much. And I just wanted to say, vocalizing what everyone has said already, it's really an amazing talk. This is such a wonderful introduction to this field, and really great to know about all the exciting work that's going on there. So yes, so exactly the question you read is I think on a lot of people's minds right now, and it's really great to hear your feedback there. Maybe the next question, I think it's slightly related actually, which is coming from Renee. And they're asking, how do you know that anesthetized individuals are really unconscious?
That's a great question. We actually don't know that. This is a big debate right now. And anyone who's about to have major surgery maybe just wants to mute for the next little bit. But it's an open question about what anesthesia is actually doing. Are we actually making someone unconscious? Or, as Robert Sanders has been arguing, are we just disconnecting them from their external the external environment? So people are there are many individuals who argue that the dimensions of level and contents of consciousness or wakefulness and awareness is not sufficient to explain anesthesia. Many people argue that there should be a dimension of connectedness. So, for example, dreaming, we have subjective experience, but it is a disconnected experience from our external environment. And so there's some people who argue that anesthesia just disconnects you from your external environment and makes you amnestic, so you can't remember what's happening during the surgery. One of the interesting findings of this, you can actually see this on YouTube, is the isolated forearm test. So there's if you look at isolated forearm test, you'll see that individuals who are under anesthesia, who are in the middle of a major surgery, who have had a tourniquet applied on their forearms so that their arm does not get paralyzed, is able to answer questions and respond to commands with their hands. Open your hand twice, show me the number 4, and they will do this while they are under anesthetic and in the middle of surgery. So it's an excellent point. We don't know for sure that individuals are unconscious when they're anesthetic.
Wow, and that's really just an amazing kind of demonstration of that you pointed to. That's really, really fascinating. I do think we have time for one more question. And so I just wanted to hear your thoughts from Andy Dijkstra asks, what do you think of the work showing posterior dominance of EEG activity during conscious states? And what does that imply about the front of the brain, back of the brain debate?
That's an excellent question, and that's a really hot topic in consciousness science right now. Where is the locus of consciousness? Is it in the front or in the back of the brain? And there's been a number of really convincing articles published on both sides. I think some of the most convincing ones are when they done in rats, not in humans, but they will take rats, anesthetize them, and then stimulate either electrically or through chemical means, stimulate the various areas of the brain, and they're able to reverse the consciousness state of the rat, even though they are still inhaling the anesthetic. And they've been able to show it in posterior and in anterior regions. In terms of, Andy, your comment about what do I think about the work showing the posterior dominance of EEG activity, there's a lot of work that points to a posterior hotspot in around the precuneus that are implicated in a lot of conscious states. And a lot of really interesting work that's being done with no report paradigms right now that are trying to start allowing people to look at whether someone is able to consciously perceive a stimuli without having them to push a button, for example, to show that they perceive it, that are also isolating posterior regions as the major hotspot in terms of consciousness. But Andy, it's still very much a actively debated region in consciousness science right now.
Well, with that as a really exciting future discussion topic, I'm sure, I just want to thank you again for such a fantastic talk, Dr. Blain-Moraes, and just encourage everyone listening, exactly as you said, if they're interested, please get in touch with you and learn more about this really exciting field. So thank you. And I think with that, we will move on to our next speaker. So thanks so much.
Thank you very much.